Dear colleagues, welcome to this EUROPREV webinar. I am very happy once again to be with you all. I know you are in different parts of the planet, in different continents, so be very welcome to this session. With me is already Ricardo Fontes Carvalho. Ricardo is a colleague from cardiology. He usually works a lot here in Portugal with us, family doctors. He makes a lot of medical education, a lot of webinars with us. And Ricardo, welcome. You are in this session, in this EUROPREV session. EUROPREV is the Wonga Europe Network for Prevention and Health Promotion. And we are very happy to have you with us. I would also like to say that Ricardo is working as a cardiologist in the hospital of Vila Nova de Gaia, near Porto, Portugal. And he's also a professor and researcher in the Faculty of Medicine of the University of Porto. Ricardo. Hello.
Hello. It is a pleasure to be here with all these people from around the world. Thank you very much for the invitation. And it is indeed a pleasure to be here talking about education around the prevention of stroke, which is very important all around the world.
What is going to be the program, Ricardo?
Today you asked me more or less to discuss a bit the role of the new anticoagulants in stroke prevention in atrial fibrillation. So what we will see is, you know that these oral anticoagulants, we cannot say that they are new because we already have a 10-year experience with their use.
But so it's been quite a revolution.
Yeah, it has been a completely revolution. I would say even more, it has been a paradigm shift in the way on how we treat the patients.
And there are still so many doubts about how to handle with these new treatments. And
also, which is something that is very interesting, is some heterogeneity in the use because of co-participation issues, of reimbursement issues. And so what we will try to discuss is the evidence behind the use of these NOACs. So what we will try to do is briefly review what has been this journey around this in the last 10 years. And then we will have three clinical cases so that we can discuss some practical issues that are still very interesting to discuss around the use of this kind of agents to treat patients with atrial fibrillation. And we will see how the evidence that has been built with this kind of clinical trials has translated not only into the guidelines, but also into our clinical practice in the way on how these agents were able to better treat the patients, but also one thing that is important on how we are now treating more patients with atrial fibrillation, and in this way we are preventing more strokes in this kind of population. So this is more or less the menu for today.
Okay. We have here in the web chat many messages and good evening messages from Ukraine, from Portugal, from other countries that I don't manage now to read, from Macedonia, Nicola. Hi, Nicola. I would like to share with you one or two important informations. First, we will have during this webinar some questions for your participation in which you can answer via a televote system, a televote software. So to participate in our televoting questions, please go to the link that I just shared in the web chat and leave it open during the entire webinar. Leave it open in another tab or in another browser, web browser, so that when the question will arise during Ricardo's presentation, we will ask you and we will update this link so that you can vote and answer the questions. Okay? Now, another topic, just a moment. The other topic is related with the certificate, the final certificate. If you are interested in obtaining a final certificate of this EUROPREV webinars that we are organizing during this year, you will have to confirm your attendance during this webinar. To obtain the final certificate, it is necessary to attend at least 5 of the 6 webinars, okay? How do you do this attendance check? We will share a link during the webinar, more at the end of the webinar, and you will have to access a Google form through this link that I'm going to share, and to fill it and to submit it. And so you will do your attendance check, okay? So, Ricardo, good evening from Ireland. Hi, John Cox, okay.
Hello, everybody.
Katia from Latvia, Jasper Foss from Denmark, Vinicius from Brazil, Natasha also from Macedonia, and Rosario Falanga, he is not seeing or hearing anything. No, we don't problems with connection. No, we don't have problems with connection. I would advise you to refresh the web page or try in another web browser, okay? So, we are now going to start. Ricardo, please have the word.
Okay, thank you. And one thing, I think people can ask questions also through the chat if they want in the middle of the webinar.
Yes.
So we will try at the end or in the middle to answer your questions from your clinical practice.
Yes, that is very important. I had already written here in the chat. So please share, don't be afraid to share your questions, your doubts, or even your experience in your country, in your clinical practice. This is the spirit of these webinars. We are here sharing experience with each other and also sharing our doubts so that we all together can learn more and serve well and better and take good care of our patients. Okay?
Okay.
Ricardo.
Let's go. So, very briefly, what we will try to discuss today is more or less what is in this slide. So, we will start with reviewing the evidence behind the use of NOACs, especially in clinical trials, and how this translated, as I said, into the clinical guidelines. Then we will discuss some of the tips and tricks of the clinical guide on how we can use these agents in our clinical practice, and we will discuss with real-world clinical cases what are the strategies, not only to reduce the risk of stroke, but something that is also very important, to reduce the risk of bleeding related with the use of these agents. So, I will start with a brief question, because as we discussed before, it is interesting also to understand the experience of the people at home with the use of new oral anticoagulants in their clinical practice, because as we said, all around the world, the experience is quite different and quite heterogeneous. And so that we can understand how people use these agents, I have here a brief polling to start this discussion and to test how we can use also this polling platform. So the first question is, what is the clinical reality in your country when prescribing the use of new oral anticoagulants in patients with atrial fibrillation? So the first option is, I still use warfarin or other vitamin antagonists of the vitamin K in my clinical practice. The second alternative, I use NOACs in most of my patients with atrial fibrillation. The third option is I use NOACs only in patients who are not very well controlled with warfarin or another vitamin K antagonists. And the final one, I don't start anticoagulation because I need to send the patients to the hospital or to other specialty to start these new agents.
Okay, and we have already some answers. And Anna from Estonia, she shared with us as we have 90% discount for NOAC use for atrial fibrillation, it is easy to convince the patients to use it.
Okay, yeah, that's true. In several European countries, that is the reality. But we also know that in others, especially because of reimbursement issues, there are several countries who we can only use NOACs if it is not well controlled under warfarin. So you have to start warfarin, and then only if the INR is not very well controlled is only then when you can start the NOACs. So this is quite heterogeneous, and it is a good way to start this discussion.
And Claudia from Portugal says about the question in the poll. I work in a Model B USF. USF in English means Family Health Unit. In Portuguese, it's Unidade de Saúde Familiar. So it's a primary healthcare center. And Model B means it's a primary healthcare center with pay-per-performance system. So she works in this kind of health center, and the medication cost is accountable for the goals that we have to achieve. So in general, we are under pressure not to prescribe them.
Yeah, that's the problem, and it's not only the Portuguese reality, but there are also other countries where, because of cost issues, they still try to limit the prescriptions of these agents. So we can see that exactly in this polling, we are seeing exactly this, which is there is an heterogeneity in the way on how we use these agents across Europe, but also across the world, and this is something that we were expecting. So, based on this, what we will try to do is, as I said before, to review what is the clinical evidence behind the use of these agents, and then the application in clinical practice on how we treat patients. So, we have to go back some years ago and to understand why did we need at that time the use of new oral anticoagulants. We needed this because we had a problem with warfarin and with vitamin K antagonists, and we needed some agents that could be able to do this, which is interesting in our clinical practice. An agent that would be rapid in onset, so once the patient starts this medication, immediately after 2 hours, he is immediately anticoagulated. The second thing that we would like to have as doctors is to have something that could be reversible, so that after stopping the medication in some hours, 24, 48 hours, we could have the reversibility of the effect, and then we would like to have something that we were not able to get with warfarin. Few interactions, especially interactions with other medications, and also that we could have a predictable anticoagulant effect with no need for monitoring. So when we started this journey at the beginning, what we wanted was something quite simple, which would be, we would like to have some agents that would be more comfortable than warfarin, not only for the patient, which would be easier for them to take this, but also for the doctor, because it would be easier for the doctor to prescribe this kind of agents. So throughout this journey, we learned a lot with the use of NOACs in clinical practice. A lot of evidence came from atrial fibrillation with the use of these agents for anticoagulation in atrial fibrillation and for stroke prevention. This is what we will discuss mainly during the webinar today. But we understood also that these agents would be also very interesting for the treatment, but also prevention of venous thrombosis, and also to treat an important disease which is associated with a significant mortality, which is the treatment of pulmonary embolism. So this is the three main areas where we are using NOACs in clinical practice. But one of the advantages also is that with the implementation and with the initiation of these agents, we had a lot of clinical trials testing the use of these agents also in other diseases. And here we see that some of these experiments were not successful stories. So not always in the history of the development of these agents not every time there was a successful story. And there were unsuccessful stories, for instance, with the use of these agents in cryptogenic stroke, which was quite recently published in the trials in this area. We know that these agents are not, will not be able to replace warfarin in patients with mechanical prostheses, because we had clinical trials showing that this is not effective in this context. And also very recently, also in the last year, in heart failure with reduced ejection fraction, this is not the kind of agents that should be used in this indication per se in the treatment of this disease. But it's interesting to see what where are we also expanding? And this is the most interesting part to me, which was the use of these agents allow us to better understand not only the physiopathology of the disease of atrial fibrillation, of venous thromboembolism, but also to build new avenues of research to use small doses of these agents also to treat coronary artery disease. So what we have learned is we improved the knowledge around the disease, and with this we are using these agents to treat new diseases.
Ricardo, in those previous cases of unsuccessful stories, what were the problems? The NOACs didn't work, or were also some harms associated with
this is very interesting, because in some trials you saw that there was some harm. The example is the mechanical prosthesis, because when they were tested, especially immediately after the surgery, in this kind of patients with mechanical prosthesis, you see that there was an increase in the thrombus in the prosthesis, so possibly you have a harm here. And in the other two scenarios, with the cryptogenic stroke and with heart failure with reduced ejection fraction, probably the thing is it didn't work, and there was a slight increase in bleeding. So at the end, there was no benefit in testing this in this kind of two scenarios. So we have a mix of the two in these two indications. So what we are now concentrating, especially in this webinar, in the prevention of stroke in atrial fibrillation. So we will briefly review the evidence behind the use of these agents in atrial fibrillation and in the prevention of stroke in atrial fibrillation. As you can see here, there are 4 very large clinical trials showing that compared with warfarin, this kind of therapy is at least non-inferior in terms of prevention of stroke, and probably, and with some agents we saw this, it would be probably superior to the use of warfarin. So we can see here a lot of patients that has been tested. So this is a good example of evidence-based medicine, because in fact these were most of them very well conducted clinical trials, which allow us to test with very rigorous terms the use of these agents compared with NOACs. It is true that these clinical trials are somehow a bit heterogeneous. They tested different kind of populations. This is also good, because it is important to test in different levels of risk of stroke. But in general, I would say, and to sum up, this very well-known meta-analysis that was published in Lancet, which in general compares all these 4 clinical trials with the use of NOACs compared with warfarin. So what we saw in this meta-analysis of the clinical trials was more or less, this is the summary. In terms of efficacy, this is what this slide shows, is efficacy. We saw a significant reduction in the risk of stroke and systemic embolism of about 20%. Another important thing, which was the risk of intracranial bleeding, is very much reduced when you use NOACs compared with warfarin. And at the end, even with a very effective therapy, which is warfarin, even compared with a very effective therapy, these kind of agents have shown to reduce the risk of all-cause mortality, probably mainly because of this reduction of intracranial bleeding. So this is what we saw in the side of efficacy. In the side of safety, we saw some heterogeneity, because you can see that in some trials they proved to be more safe compare with warfarin and in other trials, not that much. But in general, as I said before, the signal, especially of the reduction of intracranial bleeding, is very consistent. And in fact, we have a very good reduction in the risk of intracranial bleeding.
Okay. I see that in this meta-analysis, Aristotle's study is included.
Yeah.
I have here a question from Miriam from Spain.
Yeah.
She asks, what about the new news about Aristotle results? I don't know if you are aware about the new news.
Yeah, I understand. Our colleague is asking because very recently there was some news that some of the data of the Aristotle could not be very convincing because the regulatory agencies ask for some more detailed information regarding the use of the Aristotle, and they were not able, the investigators did not provide all the information. So there are some people, although I'm not sure if this is real yet, but we still have to understand. There are some people saying that these results should be interpreted with caution because we don't have all the data, and there are even some people saying that could be some fake data around this trial.
There could be some bias.
Some bias, okay? So I think for now we have to be cautious, see exactly where we are going to, but I think the main message, and this is something that we will see, and it is very consistent, not only in the clinical trials, but also, as I will show, in the real world. These agents have proved that at least they are, in terms of efficacy, as good as warfarin, and this is very clear in all the data. The reduction of intracranial bleeding is also very consistent. So I don't think that at least these two messages are very clear from the evidence that we have around the use of these agents. So this is important also. We have shown mainly the data from the clinical trials, and the clinical trials should be the basis for the demonstration of the efficacy and the safety of the drugs. But after this, and with this 10-year experience using these agents, we now have a lot of real-world data with very large databases, and this is also important information, especially to understand the safety and if there are some rare side effects. And I will sum up also that the real-world data are convincing, and they are more or less the same as what has been shown with the clinical trials, okay? So my message is mainly a message of consistency, not only from the clinical trials, but also from the data that we have around the real world data. The thing that is not so convincing to me is some data from the real world, which try to compare the different NOACs against each other, because there is a lot of heterogeneity on how we use this. And even if you do propensity matching, you know that propensity matching cannot account for all the variation in the use of the agents. So I would interpret this data, which try to compare NOACs against each other, with some concern, because we have to see very well the details, because there are a lot of real world data around this, some positive, some favoring one and other favoring the other. Okay. So the message that the question that you asked me, it was if NOACs is an example of evidence-based medicine. And I think that this 10 years experience, not only the clinical trials, but also the real world, show us that this is a good example of good evidence-based medicine, okay? So this is the message, the first message that we would like to convey. So
I must confess, I like very much this slide that you shared, this David Sackett evidence-based medicine slide. And most of all because it integrates from the beginning, the concept of evidence-based medicine integrates from the beginning the patient's values and preference.
Yeah, exactly.
And in this topic, it is really important.
Yeah, we started exactly by this, yeah, because this is also very important in this kind of topic, because when we started this journey, we would try to concentrate on the patient's values and preferences, on having something that could be easier for the life of the patient, but also of the doctor. This is also important because I will show you some important data on how this use of these agents allowed one thing that is very important, which is an increase in the use of a therapy that protects against stroke. Okay, so this is also important. And also, as it is here in this slide, evidence-based medicine is not only scientific things, but also integrate this clinical judgment, the values, the values of the patients, and integrate everything around the treatment of the disease. So thank you for the comment.
Okay,
so,
if I may, I would like to share some countries' experience. For example, Marina from Bosnia. In Bosnia, only with a cardiologist reference and only for 6 months on prescription. Otherwise, patients paid the full price, that is about 50 euros for the NOACs.
Okay.
And then I asked her, and if you prescribe warfarin, do patients also have to pay the full price? And she answered, no, warfarin is on prescription, patients don't pay. Rosario, in Italy, the GP can prescribe NOACs only with the authorization of the cardiologist. And then supper. In Turkey, sorry, it's not possible to test INR, PT, APTT in family medicine.
Okay, I think this is an example of practices that I don't agree. Why? Why I don't agree? Because I think this is the kind of things that should be able to the prescription to the family physician. Okay, this is
primary healthcare
from the primary healthcare physician, because the relevance of the prescription in stroke prevention is so important that should not be only the cardiologist prescribing these medicines, okay? So I understand this is a way that the government uses.
This is a cardiologist talking.
Yeah, I am a cardiologist talking, yeah. That's true. So,
but this is very interesting, this information that you are sharing with us, because it's the reality, and we may see that there is such a huge heterogeneity among family physicians working in different countries of the world. Very, very interesting. Thank you for sharing it.
Yeah, but as I said before, I think this is not a good example of good practice, okay? Because I think this should be able to be prescribed not only from cardiology, but also from people from our colleagues from general practice and primary care physicians. So, how does this evidence translate into the guidelines, and how did this change the guidelines? In fact, the evidence base around this has changed completely the way on how we treat atrial fibrillation. And it changed to the view that the first thing, as you know, to decide if the patient should be anticoagulated or not in atrial fibrillation, the first step is to calculate a score that I will show in a minute with the clinical cases, which is the Schatz-Vask. When the Schatz-Vask score is 1 point or higher than 2, now the guidelines say that the preference, because of the results of the meta-analysis that I showed, is to give the NOAC instead of giving the warfarin or the vitamin K antagonist. So the guidelines change in favor of the use of this agent. As I said here, this is a level 1A, which means the best level of scientific evidence that a NOAC is recommended in preference to a vitamin K antagonist in the treatment of atrial fibrillation, as long as you see in this slide, the patient does not have a mechanical heart valve or does not have a severe mitral stenosis, which are still contraindications to the use of these agents. We will discuss some details in a minute. So, this is how this translated into the guidelines, but one thing that is even more interesting is that the investigation around the use of NOACs in clinical practice, as I said before, improved our understanding of the disease. And two old dogmas that were around the treatment of atrial fibrillation completely changed with the investigation that the NAWACS allowed us to understand. The first example is the role of aspirin for stroke prevention in atrial fibrillation. And we can now say, based on clinical trials, and especially on this clinical trial, which few people know, but this is a very important clinical trial, which compared in atrial fibrillation aspirin with the use of one of these new oral anticoagulations, which clearly show us that the use of aspirin in atrial fibrillation is not a recommended therapy. Why? Because it does not give us efficacy in terms of stroke prevention. And as you can see here, although some people at the beginning use this to have less bleeding, we know now that aspirin has more or less the same risk of bleeding as the use of NOACs. So our understanding now, and this is what is in the new guidelines, is that in atrial fibrillation, the use of aspirin should not be used because, as it is said here, is not to treat the patient, but probably it is more to treat the prescribing doctor who is feeling that he is doing something, but actually he is not doing anything for the patient. So this is something that it was possible to understand with these trials. So what do the guidelines say nowadays? That in treating atrial fibrillation, antiplatelet therapy is not recommended for stroke prevention in this kind of patients. So this is a very clear message.
So this is important.
This is a really important message.
In patients with atrial fibrillation, we shouldn't use aspirin for stroke prevention.
No. Okay.
Is there any other case we should use aspirin in patients with atrial fibrillation?
No.
Is there any exception?
No, there is no exception.
After a myocardial infarct?
I will show you in a minute, okay?
Okay.
This is the second message from the guidelines. Even when we have a patient which is doing aspirin or other antiplatelet agent for a long time because he had a previous myocardial infarction or a previous stroke, the guidelines now say that very clearly that if you have to start an anticoagulant, and this happens also with warfarin, if you have to start, you should drop the aspirin, okay? What is the exception? The exception is only the first year after myocardial infarction, because, and this is also new evidence, which is how should we treat patients who have at the same time an indication for anticoagulation and who had a myocardial infarction who had to be treated with a stent. So some years ago, and this is very recent evidence in the last 2 years, we usually treat these patients usually with aspirin, clopidogrel, and warfarin. So we used what we called the triple antithrombotic therapy, and usually we use this for 1 year sometimes. This was the previous recommendations, using this triple antithrombotic therapy. And it was the investigation around the use of NOACs, as you see here, in several clinical trials, that actually allow us to better understand what should be the best treatment strategy in the first year of after a myocardial infarction, because this previous treatment was not evidence-based, okay? Because this is important to say that before this, there was no clinical trials saying that this should be the best treatment strategy for this kind of patients. So what we understood from these 3 clinical trials, I'm not going to enter into all the details because this is a complex topic, it could be a topic for a different webinar, but what we have understood is that we should reduce the duration of triple antithrombotic therapy, probably nowadays maximum 1 month of triple antithrombotic therapy. After this, drop the aspirin, and probably 1 year after the myocardial infarction, drop the clopidogrel and keep the anticoagulation. So the guidelines are actually changing, saying what I am saying here. So in the first month, probably we should use still this triple antithrombotic therapy, but we should try to reduce the duration of this triple antithrombotic therapy. The second thing that we understood is that, especially in this first year after myocardial infarction, where you have to combine sometimes an anticoagulant with aspirin, the preference should not be the VKA antagonist and should be a NOAC in this kind of patients. So, two good examples on how we improve the understanding of the disease, and with this we treated better our patients in these two clinical scenarios. Okay? So,
I have already some questions from the colleagues.
Okay.
May I, or later?
Probably we will have a question in a minute.
Okay, okay.
So, just to finalize this first part where we try to review the evidence, which is what was the impact, for me, the most important message for the introduction of NOACs, and this is one of the main reasons why I think that these therapies should be available to all physicians and not only to cardiologists, because of what I am going to show now. Some years ago, the treatment, the use of antithrombotic therapy in atrial fibrillation, we had a very important problem. Why? Because more than 50% of the patients were not correctly treated according to the guidelines. We saw here that there was a very large portion of patients that did not receive antithrombotic therapy, and as you can see, a lot of patients were receiving, for instance, aspirin. And one of the things that we are now understanding, and this is what happened in the last years, was a very significant increase in the number of patients with atrial fibrillations which are receiving effective therapy for stroke prevention. So, at the end, what we are having is that the rates of anticoagulation increase very significantly to almost 75% nowadays, and we can say now that these agents allow us to have a democratization in the use of antithrombotic therapy in atrial fibrillation. Okay, this could be interesting, but the most interesting thing is what are the benefits of this increased use of these agents. We are now having some data, and these data are coming from the UK, from large databases of patients, showing us two things. As you can see, over the years, with the use of NOACs, there was a significant reduction in the use of aspirin, because as I said before, we understood that aspirin should not be used in stroke prevention in atrial fibrillation. There was a very significant increase in the use of anticoagulation, as you can see in this slide, but more interesting is the benefit that the patients are having. And so what we are seeing now, and this is not only UK data, we are seeing this in other databases, is that the reduction of stroke rates is having an impact on the reduction of the number of strokes that are prevented in our clinical practice. So this is not only a question of preference, of being more comfortable to the patients and to the doctors, but the evidence has shown us that more patients are being treated, and with this better treatment, there has been a reduction in the rates of stroke and in the prevention of stroke. So this is a very clear message from the use of NOACs in our clinical practice. Any questions?
Now share some questions? Okay. First, we have a comment from Uwe Poppert from Germany. Hallo Uwe, wie geht's? And Uwe is the EUROPREV delegate from Germany, so I already know him.
Okay.
And he says, hello to all from Germany. Not surprised that the European Society of Cardiology guidelines are very much pro-NOACs. The European Society of Cardiology is financed by pharmaceutical industry by 76%. Do you want to
I want
comment?
to comment. Okay, I have no problems in commenting this. I think okay, this is true, okay, which is all the scientific societies have a significant part of financing from pharmaceutical industry, but I think that the amount of scientific evidence around this issue is so consistent that I think this is not an issue of influence of the pharmaceutical industry. I think that nowadays the best treatment, because of what I showed this, not only because of the data the comparison with the warfarin, but because of the second part that I showed us, which is more patients being treated, I think these agents came to improve the treatment of the disease. So this would be my comment.
There is also a matter of comfort for the patient, because
that's what I'm saying. Exactly.
No control needed and so on. So
and you have to think that
they don't have to go to the laboratories so often as they had with warfarin and so on.
The impact that this kind of controls and monitoring have in the life of the patient
and
is so significant.
And
costs,
costs.
Also not only of the patient, but sometimes they have to go with the son or with someone else to do this kind of analysis, to have the prescription of the thing, that it is so different, the comfort for the patient, that even if it was only this would still be an advantage. What we could question is the cost effectiveness of...
I was talking about that.
Yeah, okay. The cost effectiveness of this in relation with warfarin, okay? And as you know, cost effectiveness data should be interpreted in the differently according to the country where you are working on, okay?
The cost effectiveness studies depend from the reality of each country, because the value of the procedures of the laboratory tests is different in different countries. Even the cost of the drugs, of the warfarin or of the NOACs, is different. But there are, in some countries, studies comparing, and in some countries, the strategy is this new kind of treatment is cost effective.
Yeah, most of the data, and there are hundreds of cost effectiveness analysis. And in general, usually we consider, depends on the country also, but we usually consider the strategy as cost effective if the cost is lower than 30,000 per quality gain for the patient. And most of these analyses are positive in terms of cost effectiveness of the agents. And now what we will see in the next 2 years is that there will be generic drugs also with the use of NOACs. So this will be also will decrease significantly.
Okay. Now, Susana Silva, one question. Should we not use NOACs in a patient with atrial fibrillation and heart failure with reduced ejection fraction?
No.
Should those who are already on medication to exchange to warfarin? Thank you.
Thank you for the question, because some people could not, probably did not understand what I was showing in the previous slide. If the patient has atrial fibrillation and reduced ejection fraction, we can use NOACs, and this has been tested in several clinical trials, because in the trials that I showed before, a lot of these patients had heart failure with reduced ejection fraction. It didn't work in patients who were in sinus rhythm and had at the same time heart failure with reduced ejection fraction, okay? So in atrial fibrillation we should not use in patients with sinus rhythm and heart failure with reduced ejection fraction, which is quite different.
Those patients should change to warfarin?
No, these patients should not receive any anticoagulation, okay? A patient with heart failure, reduced ejection fraction, which is in sinus rhythm, should not receive anticoagulation, okay? So this could be something that was not very clear from the slide that I showed before.
Okay, Miguel, once you talk about aspirin, several recent studies showed no benefit from aspirin in primary prevention, and as you said, in atrial fibrillation stroke prevention. However, in a patient already taking aspirin in these scenarios, is it safe to prescribe to stop the aspirin? I don't find literature about this.
Okay. This is a good question. In fact, we don't have time to discuss all the data, all the recent data from the use of aspirin in primary prevention. But as the colleagues has said, in the last 6 months, so this is very recent evidence, we had 3 very large clinical trials within different kind of patients, all in primary prevention, where aspirin was tested. And in fact, all the trials showed us that probably the benefits will not compensate the increased risk of bleeding. So what we are now understanding is that aspirin in primary prevention should not be used in most of these patients, okay? Also in patients with atrial fibrillation, as I showed before. The question of the colleague is if it is safe to drop the aspirin in a patient who is doing aspirin for primary prevention. What I am doing, this is my clinical practice, and I can share my clinical practice, is that I am stopping the aspirin in most of my patients that I receive in primary prevention, okay, in most of them. But because the data that we have, recent data, show us that the bleeding risk is very significant and the reduction in ischemic events is not that clear. And so what I'm doing in most of my patients is dropping the aspirin. Okay.
Okay, there are more harms than benefits with the use of aspirin
it seems to be.
in primary
very
prevention.
Clear, very clear.
Now, about those patients with heart failure that you mentioned with sinus rhythm, Claudia asked, even if it is paroxystic atrial fibrillation?
Okay. This is an important question and also a very clear message. The way on how we treat paroxystic atrial fibrillation should be the same on how we treat the patient with permanent atrial fibrillation. So the decision to anticoagulate or not the patient is based on the Schatzvask score and not on the type of atrial fibrillation that the patient has, okay? We will have a clinical case exactly about this. Okay? So we are getting a bit behind the schedule.
Okay, okay. At the end of the webinar, I will try to share the other questions that are still remain without answer, okay? If we have time, I cannot promise, but we will try, Ricardo.
Okay, so until now we have reviewed the evidence, how this impacts the guidelines, and now we will see how we can use these agents in our clinical practice, okay? The clinical guide on how to use the NOACs. I will not be able to review all the evidence behind this, but this is an important document for most of our colleagues that I advise you to read, because it has a lot of practical tips on how to initiate, how to stop, and how to manage the use of these agents. It is quite recent and it is very useful for our clinical practice. So what we will discuss here, it will be based on this document, okay? So what we will try to do is to apply the scientific knowledge to treat real-world patients that we had recently with atrial fibrillation, okay? So we will start with a clinical case, and the first clinical case to make it more easier for the people to understand, it is the grandfather of Bart Simpson.
The Simpson family.
Yeah, Simpson family.
He's on the throne.
Yeah.
But not in the Games of Thrones.
Not in the Games of Thrones, yeah. But it is an interesting case because it is very similar to the grandfather of the Simpson family. Because this was a 89 years old male, which was retired. He lived alone, and he had an hypertension. As you can see, the past medical history was quite normal for this kind of patient. He was walking with a walking stick. And this is an interesting patient because he came to a regular appointment because he didn't have any new symptoms, but because he wanted to show us the previous, a recent echocardiogram, which had a moderate aortic stenosis and a normal systolic function, okay? So, but when we were evaluating the patient, we realized that the patient had an arrhythmic pulse. So he had no symptoms, but we could see that in the pulse palpation, he had an arrhythmic pulse. So we decided to ask for an electrocardiogram for the patient because of the arrhythmic pulse. And as you can see here in this electrocardiogram, you don't see P waves before all KRS. You can see there is an oscillation of the baseline, but this is not organized P waves. And you can see that the RR intervals are irregular. So what we see in this slide is that if you don't have P waves and you have an irregular RR interval, you have the diagnosis of a new onset atrial fibrillation. We don't know exactly how long ago did the patient had these symptoms because he didn't have, he had the atrial fibrillation because he didn't have any symptoms of atrial fibrillation. So the first message, the first take-home message that comes from this case, I think it is very important for our clinical practice, because it is advised nowadays that these patients we should do in our appointments with the patients what we call an opportunistic screening of atrial fibrillation, which is something very simple, as taking the pulse of the patients who are elderly, because we know that a lot of these patients with atrial fibrillation, especially if they are elderly, they don't have very significant symptoms, and usually they have what we call a subclinical or a symptomatic atrial fibrillation. Now we are going to new devices like the Apple Watch and other devices who are doing this kind of screening. But for now, what we advise people to do is something very simple, which is shown here in this very famous Picasso painting. Doesn't seem to be a Picasso, but it is very interesting to see, because you see here the patient just taking the pulse of the patient, and this is important in elderly patients to do this screening of atrial fibrillation, which is important. So we have a question for the people at home, which is interesting in this clinical case. Remember that we have a patient with 89 years old, and what would be the recommended antithrombotic therapy in this kind of patients, okay? So people will be able to vote at home. We will have here the polling so that people can use the browser, the link to vote, and what would be the recommended antithrombotic treatment in this patient.
Okay, we have to wait for some minutes because we have some delay. I will share with you another question. Claudia said, sorry, I am lost. In primary prevention, we should not use NOACs and platelet inhibitors. And in secondary prevention, we may use it, but in a short period of time, or not use it at all. Is that it?
Let me go and organize everything,
yes.
Okay? Okay. First thing, if we have a patient with atrial fibrillation, okay, atrial fibrillation, you should use NOACs if the Schatz-Vask score is higher than 1 point, okay?
And that has nothing to do with primary or secondary
prevention.
Okay.
Primary prevention, a patient which doesn't have atrial fibrillation and did not have any kind of cardiovascular event, the data that we have now, if he is in primary prevention, is that aspirin should not be used in primary prevention, okay? So what is the role of aspirin? Aspirin should be used in patients with a previous cardiovascular event, okay? Another completely different thing is the patient that has at the same time atrial fibrillation and had, for instance, a myocardial infarction, okay? If the patient had the two, that was the kind of patients that I said before that we used at the beginning the triple antithrombotic therapy, okay? Just to organize the ideas.
Okay. And now we have already some answers. 84% of our colleagues answered NOAC is recommended in this patient.
Okay, this is a very interesting answer because although most of people answered 85% that they would use a NOAC, in clinical reality, and we see this in a lot of data and scientific evidence, is that the doctor is usually afraid of giving anticoagulation in patients who are elderly, especially if they have older than 80 years old. Okay?
We have an interesting comment from Shatzimanolis. The older people with comorbidities and polypharmacy are in greater risk of hemorrhage, because many cardiologists in atrial fibrillation prescribe clopidogrel and aspirin.
Okay, first part of the answer. If they use aspirin and clopidogrel for atrial fibrillation, they should not use, okay? As I said before, nowadays there is no role for any kind of antiplatelet therapy in patients with atrial fibrillation per se, okay? So the decision is to use anticoagulation or not to use anticoagulation. So the first thing that we know nowadays, and there are a lot of evidence around this, is that this decision of anticoagulating or not the patient should be based on this score that is here calculated. And as you can see here, the patient had hypertension, was older than 75 years. So 2 points here, 1 point here. He had 3 points. And so, as I said before, he has an indication to receive anticoagulation. Some people are a bit afraid of giving anticoagulation to this kind of patients because sometimes they can fall, they can have some kind of bleeding event which is related with this more vulnerability that these patients have. The data that we have nowadays are two data. First, we know from several evidence that the age per se is not a contraindication for anticoagulation. The second thing is that an arbitrary risk of falls, this is not the patient who is always falling and we, balancing the risks and benefits, sometimes decide not to anticoagulate. But as a general risk of fall, so we know that the patient has to fall more than 300 times a year not to have the benefits of anticoagulation if he has a Schatz-Vask score which is high. And the third part is that in the beginning we said that Hasbled could be used to decide if the patient would benefit or not from the anticoagulation therapy. Hasbled score is a bleeding risk score, and we know now that this is not a contraindication for anticoagulation in atrial fibrillation.
Okay, correct me please if I'm wrong,
Yeah.
but I think we have here an important take-home messages that is, if we find a patient with atrial fibrillation, permanent or not, paroxystic or not, we have to assess the Schatz-Vask score.
Exactly.
And this will tell us if the patient has indication to be anticoagulated or not.
Or not, exactly this, okay?
Okay.
The decision to anticoagulate or not is based on the Schatz-Vask score, okay? Then there could be some exceptions of patients that because of other things could have a contraindication for bleeding, okay? But the decision to anticoagulate or not is based on the Schatz-Vask, okay? So this is the first message. The second message is something that is important also to stress because there are some doubts still in the people, which is what is valvular atrial fibrillation. Because if you see in the recommendations, we see that NOACs should be prescribed in patients with non-valvular atrial fibrillation. Nowadays, we are not using no longer this term valvular atrial fibrillation. Remember that this patient had an aortic stenosis, as you remember in the beginning of the clinical case. This is the kind of patients that we could use NOACs, and I remember again that the two kind of patients we should not use NOACs is the patient with mechanical prosthesis, it is a formal contraindication, and also the patient with moderate or severe mitral stenosis. In mitral stenosis is because we don't have evidence for the use. In mechanical prosthesis is because, as you said before, there is a reduction in the efficacy of the drug. Okay, so this is the second take-home message.
Okay, about this, Tom asks, how can we know it is non-valvular atrial fibrillation? He has an aortic stenosis.
Okay, this is exactly what I am showing. What we are not using no longer the term valvular atrial fibrillation. If you want, you can use this term which has been proposed, which is MARM atrial fibrillation, just to remember that we should not use NOACs in these two type of patients. Patients with mechanical prosthesis and patients with mitral stenosis, okay? This is the two type of patients where we should not use NOACs to anticoagulate a patient with atrial fibrillation. Okay.
And about knowing the nature of the valvular problem, the ultrasound, the echocardiogram.
Yeah, the mechanical prosthesis is very easy to understand.
To listen to.
It's just do auscultation of the patient, okay? If we start anticoagulation with a NOACs, for instance, and we should ask for an echo in this kind of patients because we should evaluate the heart, not because of this issue of valvular or not, but because we need to do an echo in all patients with atrial fibrillation. If the patient has a moderate or severe mitral stenosis, then we could switch the NOAC to a vitamin K antagonist, okay? So this is how we should do it nowadays based on the evidence. Okay? So just to finalize, that even in patients with high risk, and for instance, patients with high risk of falling, and there is a lot of evidence around this, the preferred strategy should be the NOAC compared with warfarin. So the case proceeds. So the patient was anticoagulated, as most people suggested at home. He was treated because of the Schatzvask, which was increased. The patient started one of the NOACs. It started apixaban, but could start another one. And this is interesting because the patient, after 8 months of therapy, he started having an anemia with an hemoglobin of 11. Okay, so the patient had a normal hemogram, a normal hemoglobin before, and there was a drop in hemoglobin after 8 months of therapy with this. So we decided to perform an endoscopy and a colonoscopy in this patient to understand what was the cause of this anemia in the treatment of this patient. So another pulling for the people at home, which would be what would they do in this patient after knowing that there was this drop in hemoglobin and that the patient was going to be sent to do an endoscopy to understand what was the cause of bleeding.
Okay, while we wait, I will answer some questions. Jasper asks, would it be possible to obtain the slides used by mail after the webinar ends? Jasper, by mail, not, but the video of this webinar and also the slides, if you may, Ricardo, yes, will be available in the EUROPREV website. In the EUROPREV website, you have also already the video, it's already available, of the first EUROPREV webinar. This takes some days, 1 or 2 weeks, because I have to wait that video production is finalized, and then I will upload it to the website, and then you will be able to download the presentation and the slides, okay? Another comment from Uwe Poppert from Germany. How many placebo-controlled NOAC trials have been produced or have produced significant data for elderly over 85 years old in atrial fibrillation?
Okay. Regarding the use of NOACs, you don't have very direct placebo-controlled trials, because I think it's unethical to do a trial like this one, okay? You have evidence from a trial, you can search in the literature, which is the BAFTA trial, okay? Which compared in elderly patients directly the use of aspirin with warfarin, okay? In the elderly patients. And what we saw in this trial was a very significant reduction in stroke and mortality with the use of warfarin compared with aspirin, okay? And this is very clear in elderly patients. There is also another trial that I showed before that I would like to comment, which is the Aristotle trial. What did they do is patients that the doctor did not want to start anticoagulation, usually because of age, because of problems with monitoring, whatever. They randomized these patients who were not going to receive anticoagulation to aspirin versus apixaban. As I said before, it is the Aristotle trial. And there was a very significant reduction in stroke and mortality, also with the use of anticoagulation in patients that we didn't want to be anticoagulated, okay? So I think that nowadays, with all the trials, and we have evidence also from, there is a very recent data coming from Denmark, where they tested with the propensity score matching the use of anticoagulation in patients older than 85 years old, showing that these agents reduce very significantly the risk of stroke.
Okay. Are also any difference regarding the safety, for example, hemorrhagic risks, use of warfarin versus NOACs in elderly patients?
Yeah, there are some data showing this, and the thing that we see in most of, especially sub-analysis, okay, sub-analysis of the clinical trials, is that the older the patient, probably the more benefit will get from being given a NOAC versus warfarin in terms of reduction of intracranial bleeding. Okay, so this is very clear also in terms, especially of intracranial bleeding. Okay, because one of the things that we didn't discuss before is that with some of the NOACs, there could be a slight increased risk of gastrointestinal bleeding. We have this signal, okay? So an increase in gastrointestinal bleeding. But especially regarding intracranial bleeding, the reduction is more than 50% of the risk of intracranial bleeding.
But in elderly or
in general, but especially in elderly, because you know that one thing is the relative reduction and the other thing is the absolute risk reduction. Because these patients have many events, the same relative reduction in terms of absolute terms translates into more benefit.
Uwe Poppert answered, he says he disagrees.
Okay.
The decision for anticoagulation is only done after waiting the pros through Schatzvask and the cons, for example, as bled score. For over 75 years old, we know that ASBLED is probably underscoring bleeding risk.
Okay. Very briefly, I don't have here the data, but I can share with the colleague, no problem, which is, there are several data showing, testing the benefit of these agents in terms of separated by ASBLED score. Okay, which is high bleeding risk score and low bleeding risk score. And even in patients with a high ASBLED score, there is a clear benefit in terms of reduction of stroke. Okay, so this is, there are several sub-analyses showing this. This does not mean that in the patient that we have in front of us, sometimes we are not giving the anticoagulation. We have to use the good clinical sense. But refusing an effective therapy based on ASBLED score should not be done, and this is very clear not only from the evidence but also from the guidelines. What we should use the ASBLED score, and I agree with what he said, that ASBLED is not a good score for assessing the bleeding risk. This is true, but ASBLED score, as I will show in a minute, it has a very important take-home messages. For one thing, which is there are several things which are related with the ASBLED score that we can do to reduce the bleeding risk, okay? But I will show in a minute some simple strategies based on the ASBLED that will help us to reduce the bleeding risk.
Okay, we still have a lot of questions, but we have to go forward. We will try to come back to your questions later, okay? At least at the end of the webinar.
Okay,
Ricardo.
so most people...
let's see the answer.
Okay. So most people said that
49%.
Well, they would stop one day before the procedure. Okay.
Okay.
So,
is it correct?
Yeah, this is what I would do. Okay, in my clinic practice, this is what I would do, and I will explain what is nowadays the consensus around this.
Okay. Okay.
Very briefly, when you have a patient which is undergoing a surgical procedure, usually we divide the procedures in three kinds of procedures. This is what we call the procedures with a minor bleeding risk, okay, which is like dental extractions, cataract surgery, or an endoscopy without biopsy. And these kind of procedures, you don't need to interrupt the antithrombotic therapy, even if it is NOAC or warfarin, it doesn't matter, it's the same. There is the procedures with the low bleeding risk, which is an example, a biopsy of the prostate or an endoscopy with a biopsy. You should interrupt in this kind of situations 1 day. And the major surgeries, you should interrupt 2 days. So we split the procedures in three types of procedures, and we should not interrupt in the minor bleeding risk, you should interrupt 1 day in low bleeding risk, and you should interrupt 2 days in patients with high bleeding risk. So this patient was undergoing a colonoscopy. There could be a probability of having a biopsy, and therefore the decision would be to interrupt 1 day the antithrombotic therapy of this patient. So what is recommended, and this is in that clinical guide that I showed you before, is that in this kind of scenarios, this is the kind of thing that we should do. No, you don't need to do any kind of bridging, which is a common doubt that people at home, if you are using NOACs, you should not use bridging with enoxaparin or other low molecular weight heparins. It is not recommended. And as I said before, if the procedure, it is a low bleeding risk procedure, you should stop 1 day. If it is a high bleeding risk procedure, you should stop 2 days with no bridging with other type of anticoagulant strategy. There is only one exception, which is also important. If you use in a patient dabigatran, and if the patient has a clearance below 60, okay, I think in patients with clearance below 60, dabigatran is not the best option because the renal excretion of this drug is very high. But if the patient is doing dabigatran and has a low creatinine clearance, you should add another day of stopping because if it is by renal excretion, it will take longer to excrete all the dabigatran which is in circulation. Okay, but this is the general rule, which is.
Okay. For example, is there any difference if the patient is going to do the endoscopic procedure in the morning or in the end of the day?
Okay, this is especially important for the NOACs, which are given twice a day, probably. Okay, what we usually recommend is, at least if it is low bleeding risks, to stop two intakes if it is a twice a day drug, and 1 intake if it is a once daily drug. Okay, which is more or less what is in this slide that I showed you here. Okay, with the 2 days that are 2 days, and the ones, if you go into the details, the answer to the colleague is here in this slide. Okay?
Okay, thank you.
Okay, so one of the things, and this is something that we were commenting some minutes ago, is so important as reducing the risk of stroke is reducing the risk of bleeding, of course. So this comes from the Hasbled. Okay, if you go to the Hasbled score, as I said before, Hasbled score is a score of bleeding risk. It helps us to remember that some of the risks of bleeding are reversible, and this is some small tricks that you can use in your clinical practice to reduce at the same time the risk of bleeding. Things like avoiding giving to patients who are doing antithrombotic therapy NSAIDs to treat the pain, avoid corticosteroid therapy, avoid alcohol, control the blood pressure because of the risk of intracranial bleeding, and if the patient has a high bleeding risk, consider giving a prophylactic proton pump inhibitor. These measures these are very simple to take, and these measures are important to reduce the bleeding risk associated with the use of any kind of antithrombotic therapy, NOACs, but also vitamin K antagonists. Okay, so simple messages for clinical practice to improve our clinical practice. Okay, so we have a second case to discuss. The time is running, but I think it will be interesting also to discuss this clinical case. Okay, because this is the more difficult case that we sometimes have with the use of anticoagulation. Okay, so after having the grandfather of the Simpson family, we have a very famous, another famous character of the Simpson family, which we usually don't like very much. And I reuse this because this was actually a patient of mine, which was a businessman, and in terms of character, he was a bit like Mr. Burns. He was a difficult patient, I would say. So he had, it's an interesting patient because he was 82 years old. He had hypertension and type 2 diabetes. He was doing, he had a past medical history of a diabetic retinopathy. He had peripheral artery disease with claudication when he was walking. And actually he came with 1 month duration complaints of dyspnea with moderate exercise, okay? This was the medication that he was doing for the comorbidities that he had. And because the patient had this dyspnea, actually I asked him to do an EKG to understand what was the cause of this dyspnea. And as you can see here in this electrocardiogram, it's slightly different from the previous one. But here what you can see is this kind of sawtooth pattern. So the patient actually had not an atrial fibrillation, but actually an atrial flutter, okay? Which is something that it is common also in this kind of old patients that we sometimes have. So the patient had an atrial flutter. He'd also perform an echo just to understand the cause of the dyspnea. He had mild left ventricular hypertrophy. He had a normal systolic function. And as you can see here, the blood tests, he had an uncontrolled hemoglobin A1C. He had a creatinine of 1.3. And this is very important, as I said before. It is important, especially in these older patients, to determine the creatinine clearance, okay? So you should calculate the creatinine clearance using especially this kind of formula, which is the formula that we advise in patients with atrial fibrillation. And as you can see here, he had a moderate chronic kidney disease, okay? So let's go to the audience at home again, so to understand their opinion and see what would they vote in this kind of patient. If they were going to give him anticoagulation therapy or not, if they were going to give them aspirin, prefer warfarin, prefer a NOAC but use a low dose, a NOAC in a standard dose, or the NOAC should not be used because this patient had a renal dysfunction. Okay.
We have to wait for the answers, dear colleagues. For those of you interested in receiving a certificate at the end of our 6 webinars, I have already shared the link so that you can make the attendance check, okay? Please don't forget to do it. And now another question. I don't know if you are going to share this practical example. Marina asks, how can we bridge or switch if the patient use vitamin K?
Okay. I don't have here this because you mainly asked me to review the evidence around the NOACs.
And there wasn't enough time.
And there wasn't enough time, okay? And but I can share some general thoughts, okay? Which is, for this kind of procedures with minor or low bleeding risk, we are now not advising to give bridging with low molecular weight heparins, okay?
She doesn't refer to heparins. She refers to...
Okay. I'm saying is that if the patient is doing warfarin, okay, and he is undergoing a procedure, okay?
I'm sorry.
I'm saying that the patient should not receive a bridging, okay?
I misunderstood her question.
Okay,
but
no
you
problem.
understood well.
Yeah, I understand.
I'm sorry.
No problem.
I thought she was talking about changing from vitamin K to the new anticoagulants.
Okay.
But no, she was asking about bridging with the use of the vitamin K antagonists.
So my advice is, so that if she is interested, we're not able to review all this. But there was a recent New England Journal article, which is called the Bridge Trial, okay? Bridge from bridging, that she can read. And in the editorial also has some interesting thoughts on how we should do this, okay?
Okay. And another important questions from Tom. Thanks for the previous answer, but still I didn't understand the contraindication using NOAC in mitral stenosis. Okay. So what if that was never checked? What damage could it make?
Okay, we don't use in mitral stenosis. Why? Because all these clinical trials that tested the NOACs, there was an exclusion criteria, which was the patient with mitral stenosis. And therefore, because there is no evidence, it's not evidence against, it's no evidence in this scenario, we do not recommend giving NOACs in patients with mitral stenosis. Now, they are undergoing 2 clinical trials, which are being done in Africa, where you have more rheumatic mitral stenosis, testing the use of NOACs in this scenario. But we are not recommending because it has not been tested, okay? So that's why we are saying we don't know if it works or not. Because we don't know if it works or not, we are not recommending it, which is different from the mechanical prosthesis, where we know that it increases the risk of thrombosis of the prosthesis, okay?
Okay. And now 2 important questions. This one is related with the switching. Meta from Denmark. If a patient is already on warfarin treatment and is well regulated, do you recommend switching to NOAC or continue warfarin? Pedro, since warfarin has a lower risk of gastrointestinal bleeding, should the patient stop the NOAC and start warfarin?
Okay. First question. If the patient is well controlled under warfarin, I usually don't change the therapy unless the patient comes to me and says, it is my preference to change to an agent that is not going to, doesn't need to be monitored, okay? Unless the patient comes to me and says this specifically, if the warfarin is well controlled, I keep the patient on warfarin, okay? Second question, if the patient, for instance, if he has gastrointestinal bleeding, if I should switch from NOAC for a vitamin K antagonist. In my clinical practice, I don't do this, okay? What I usually do is I speak with the gastroenterologist to understand why is what is the reason of the gastrointestinal bleeding. And especially if the patient had a previous bleeding event, it is mandatory to give the proton pump inhibitor, which is the measure that reduces more the risk of bleeding in this kind of patients.
Okay, now we can look at the answers.
Okay.
76% of the colleagues answered
a low dose, okay? Okay, the message that I would like to convey nowadays is that when we started using these agents, actually in the beginning we said that this should not be used in patients with chronic kidney disease. Nowadays, we know more or less, and this is, you can look at this in more detail, this is also in that practical guide, that knowing that we can even use NOACs with adjusted dose, of course, until creatinine clearance of 15, okay? So, as you can see here, you can go until this. The second message is quite simple, which is this one. You should give, if you want to give a NOAC, you should use the labeling of the drug, which is in these scenarios, and this is a summary of for clinical practice, when you should use the low dose. When you have this criteria, depends on the creatinine clearance, of course, you should use the low dose, okay? And this is also an important message, and this is an important practical message to our clinical practice. The other thing that I would like to reinforce, and this is a common doubt from our colleagues, is how many times should I reevaluate the renal function if the patient is receiving a NOAC? And there is a rule that we usually say, this is not evidence-based, but is something that has some clinical rationality, I would say, which is dividing the creatinine clearance by 10. For instance, if the patient has a creatinine clearance of 60, if you divide by 10, it is 6 months. Every 6 months, this patient should have a creatinine to reevaluate renal function. If he is only 13, he should receive every 3 months, okay? So this is something also, a practical tip for our clinical practice on how we could monitor the renal function in this kind of patients. Why I am showing this kind of adjustment of dose? Because what is happening sometimes is that some colleagues, because they are afraid of bleeding, they are using a lot the low doses of the NOACs, okay? So we have to start the therapy. To reduce slightly the bleeding risk, we are using lower doses of, not the recommended ones, but usually the low dose. But this should not be done because there are several data showing that if the patient is receiving the low dose without criteria of dose reduction, this can result in an increased risk of stroke, okay? So the clinical message is simple, it's just to follow the instructions, okay? Just to follow what is recommended for each drug and adjust the dose if it is necessary. Remember that this patient that we were talking about, he was receiving aspirin because probably he had peripheral artery disease. What we recommend in this kind of patients, if he has a high risk of stroke because the Schatzvask is high, if we are going to start anticoagulation, we should drop the aspirin, which is what we have discussed before, okay? If we start anticoagulation, to decrease the bleeding risk, we should drop the aspirin in this clinical context, okay? So final case, this is shorter, this is a bit simpler, but it is also important, and this is related with one of the questions I think that came from Italy, okay? Okay, this is a patient that I also had very recently, which was, I would say it was like the Ned Flanders also from the Simpson family. This is a simple case because this was a healthy man, okay, 45 years old, no cardiovascular risk factors, no previous medical history, and he came to the emergency department because he was feeling a lot of palpitations after doing exercise, after running, and he was not feeling well because he had a lot of palpitations, okay? So this is the EKG of the patient, which is very interesting, this EKG. Why is it interesting? Because, as you can see here, this is the rhythm of the patient. I put this more simple for people at home to understand. The patient was under atrial fibrillation, and as you can see, there is an atrial fibrillation with rapid response, ventricular response, okay? No P waves, again, the R interval is normal. And actually, when he was doing the EKG, he spontaneously passed to sinus rhythm, okay? By chance, the patient, it was self-treatment, okay? The arrhythmia passed and then he started in sinus rhythm, okay? And he started feeling much better, of course. So, what is the question for the people at home? And I think this is the final question that we will have today. What would be the recommended antithrombotic?
One more
okay,
at
so
the end of the webinar.
Okay. You see the slides ahead. What is the recommended antithrombotic therapy in this patient? Okay, remember the patient that we are having? So, no need for antithrombotic therapy, option A. B, aspirin, 100 milligrams. C, NOAC. D, warfarin or another vitamin K antagonist.
Okay, let's go to another question from Rita. The truth is that the Hasbled score was created to evaluate the surgical hemorrhagic risk, if I am not mistaken. But many doctors, even at the hospital level, use it to consider anticoagulation or not, as waiting between Hasbled and Schatzvask.
Okay. This is, as I said before, in fact, in the previous guidelines, there was a point where the decision, the previous guidelines, I think 6 years ago, the Hasbled could be considered, okay, to decide if the patient was going to receive anticoagulation or not. But because in the meantime, these trials that I discussed before have been published showing that the reduction in events is the same in a patient with Hasbled high or low, this is no longer recommended in the guidelines, okay? So This is probably historical because in previous, some years ago, guidelines, there was this, okay, the decision based on Hasbled, but nowadays this is no longer considered, okay? The Hasbled is important for us. As I said before, it's not a very good bleeding risk score, but it's important for us to remember the things that we can do to reduce the risk of bleeding, okay?
Okay. So we can look to the answers. I
Okay.
think we have a split result.
Okay, so
55%
50-50.
say no need for antithrombotic therapy, 42 say NOAC.
Okay.
He
So-
was 45 years old, the patient.
45 years old, okay? No previous medical history.
Do you
No
have-
cardiovascular
Do you
risk
have
factors.
the Schatzbach score?
I have the Schatzbach score.
Okay,
and this is easy to calculate.
Let's look at it.
The Schatzbach in this patient is 0.
Zero.
Okay?
Okay.
So, this is to remember that, again, the decision is not based on the type of atrial fibrillation, okay? It's not because of having a paroxystic atrial fibrillation that we are going to decide if the patient is going to receive antithrombotic therapy or not. It's because the Schatzbach of this patient, as you can see here, he doesn't have any criteria, any point in the Schatzbach. So if the patient has a Schatzbach of 0, no antithrombotic therapy is recommended. It's not recommended to give aspirin, it's not recommended to give an NOAC, it's not recommended to give warfarin or other vitamin K antagonist, okay? This is based on the Schatzbach and not on the type of atrial fibrillation that the patient had. And here is the guidelines, as I said before, Schatzbach 0, no antiplatelet or anticoagulant therapy, okay? So most people got it correct, and 55% of the people had this correct. Why? What is the scientific rationale? Is because we know that if the patient has a Schatzbach of 0, see that the risk of having a stroke is very, very low. So the hazard of the antithrombotic therapy is higher, and so it is not recommended to give therapy in this kind of patients, okay? So we reviewed the clinical cases, and we have some final take-home messages. Some of them we already explored during the webinar, but I have 2 messages especially. First is review the recommendations. This is a very practical summary on how to use NOACs. If you have doubts, any kind of doubts, starting, stopping, switching, it has almost everything regarding the use of NOACs. So I advise people to use this as a guiding or a consult article. And to finalize, I think this is especially interesting because we are here in the EUROPREV. And I don't know if you know this, Carlos, you know, I know that you are in the EUROPREV, but this is a very interesting thing from the history of medicine, which some people consider that it was the first writing related with medicine, okay? So it is something that comes from China from 4,000 years ago, okay? Very old piece of writing.
I didn't know that you could read Chinese.
No, I
Mandarin.
but I will translate.
Okay.
With my capacity to read Chinese.
Do you learn these kind of things when learning cardiology?
Yeah, we learn a lot of Chinese.
Okay.
We write a lot of Chinese sometimes for our colleagues.
Imagine if you were a surgeon.
Imagine, yeah, you're right. But one of the things which is interesting is the message behind this, and which is very interesting because, and this applies to everything in life and especially in medicine, which is the superior doctors are not the ones who treat the patient when it is full-blown disease, like after the myocardial infarction, like after the stroke, etc. Superior doctors are those who are able to prevent the disease. And we are here during this webinar. We have discussed a lot of situations where we could improve and reduce the risk of stroke by using correctly the medication, but also This is important also because sometimes we only look at the risk of stroke, but we also have seen that the risk of bleeding can also be prevented, and the good doctor should be able to do the two things. On one side, in this kind of patients with atrial fibrillation, if it is recommended to reduce the risk of stroke, but also to look at the bleeding risk and to reduce the risk of bleeding with some of these measures that it is possible to prevent the bleeding risk of this patient.
Okay, I have a comment to this Chinese saying, yes, because actually in EUROPREV we have been quite concerned about the right use of prevention, because nowadays we are aware that very often with the intention of preventing,
you can do some harm to the people.
Yes.
Okay.
Okay.
But this is not preventing in the true sense
I understand.
of the thing.
Okay, superior doctors prevent disease, but with caution, with the right evidence.
But
trying
preventing
to do
the disease,
always more benefit than harm to
always,
patients.
as I said, preventing the disease is also preventing the harms associated with some of the things that sometimes we do to try to prevent other diseases, okay? So I don't know if you understand what I mean.
Sorry.
In a broader sense. I was saying that preventing the disease in a broad sense is not preventing the disease per se, is also preventing sometimes the iatrogeny
Yes.
of some of the preventive measures that sometimes we do.
Of course. So, dear colleagues, could you share the next slide, please? Sure. Yes, I am asking you one word for this webinar. Just one word that came from the inspiration of this webinar. What do you think this webinar was for you? And now we will try to answer some of your questions. We have some minutes to do it, if you allow, Ricardo.
Sure, yeah.
Okay. So, for example, Buzra asks, when the INR value is off, the doctor should leave warfarin?
When the INR
is off. I don't know if it's
off target.
Yes,
off
I
target.
think.
What we usually recommend is not only to look at a single measure, but to look at what we call the time in therapeutic range, okay? Which is something that is easy to calculate, which is more or less the amount of times that the patient is with the INR between 2 and 3. If this time in therapeutic range is below 60 or 70%, we recommend the switching from warfarin to a NOAC, okay? When it is below this range. Not only because he has a single measurement out of target, okay?
Okay. Fonteini says, usually the dentists are afraid of NOACs and they force the physician to stop it for 5 days.
Okay. 5 days is completely incorrect, okay? Completely incorrect, and this should never be done, okay? The risk of having a stroke is significant. Although what we know in terms of scientific experience recommends not stopping the anticoagulation, sometimes when this kind of dentists that want to some kind of stopping, we should stop maximum 1 day, okay? There is not harm of stopping 1 day, but it is completely wrong to stop more than 1 day for dental extraction.
Okay. Hugo Paiva, just to check if I understood correctly, after 1 year of a stent insertion in a patient with atrial fibrillation, can you discontinue antiplatelet therapy and stay just with the anticoagulant agent?
Okay. Yes, the evidence that we have now recommends that even in patients who had previously a stent and a coronary stent, they should receive anticoagulation and that we should drop the antiplatelet therapy.
Okay. Uwe Poppert, one of the major contraindications mentioned is more than 300 falls per year. But what actually was the definition of a fall into trials? Stumbling, bruises, needed help to get up?
Okay. There are some trials. I advise the colleague to read. There is a sub-analysis, which is interesting to understand this, from the Engage. You could go to the internet and put Engage trial falls. Okay, it is a sub-analysis of one of the trials, which compares warfarin and NOACs, and it has a definition of falls. Okay. So it is interesting to see how the investigation comes. What I was saying is a statistical analysis. It is true that there are some, this was also in the guidelines, in statistical terms, the patient has to fall 300 times for not having the benefit of anticoagulation. But it is true that in the individual patient, one fall could be enough for the patient to have a significant bleeding or even to die, okay? So this is just for us to understand the statistical part, okay? This was in the previous guidelines, so the colleague can go there to see the statistics behind this, but this is just to understand the statistics behind this and to see how the impact of antithrombotic therapy in atrial fibrillation. We are talking of a therapy that in terms of number needed to treat for stroke prevention is less than 20, okay? So this is a very effective therapy.
Okay, I think this was a comment about one of our cases, our vignettes. Tom, even if he had perfect sinus rhythm, he should get NOAC to prevent stroke myocardial infarction because of comorbidity, path, and DM, I think peripheral arterial disease and diabetes.
Okay, I understand. If the patient, if he had atrial fibrillation, he would have an indication for anticoagulation, okay? If the patient that we showed before didn't have atrial fibrillation, he only had the peripheral artery disease, he should receive antiplatelet therapy. However, there are very recent data showing that if you have very low dose, it's not anticoagulation, it's if you're having a very low dose of one of the anticoagulants, which is rivaroxaban, which is a very low dose, there could be a reduced risk of ischemic limb events, okay? But this is something that I will not like to go into because it is a bit more complicated, and this is very recent data that are not already in the guidelines.
Okay, colleagues, I'm so sorry. It will not be possible to answer all your questions, so I will share just more 2 questions and then we will finish this webinar. So Özden asks, I think it's more a kind of reflection questions. How can we overcome about the drugs that couldn't be prescribed by us and also the chronic conditions that we do follow up? What about policy?
Well, I think that policy, it is part of our job as doctors also to influence the politics and the politicians. And my advice is, although this is not easy, but I advise you for our colleagues who are doing clinical practice in countries which doesn't allow to prescribe this kind of agents by family physicians. I think that a doctor, not for being because of being a primary care physician, they should treat also this kind of patients, and they are not inferior doctors compared with cardiologists. So I think this should be a very strong message locally, which is every physician should treat this kind of disease, because we need to be united to reduce the risk of stroke in this kind of patients. So
Okay, final question from Beatriz Mendes. I think it's about that patient that should undergo the endoscopic procedure. Wouldn't it be different if you knew whether or not a procedure such as a polyp removal was highly probable?
Okay, yeah, I agree completely with the colleague. The problem with doing an endoscopy is that we never know if the gastroenterologist is going to do a biopsy or if he is going to remove a polyp. And because we don't know, instead of having the patient to repeat everything again, the preparation of the colonoscopy, the rationale, the best clinical rationale is, if we don't know if the patient is going to receive this kind of therapy, stop for 1 day, okay? Because the risks are not high, and if there is a reasonable chance of having a polypectomy or a biopsy, I think we should stop 1 day.
Okay. Dear colleagues, thank you very much for your participation in this webinar. You have sent us a lot of words. Excellent, interesting, fantastic, congratulations, enlightening, great, collective, arrhythmogenic, exciting.
This one is my favorite, arrhythmogenic, exciting.
Okay, helpful, inspiring. Thank you very much. I would also like to invite you to join us, to join the EUROPREV team in Porto next November. We will have our conference, the European Forum on Prevention and Primary Care. This year's main topic will be evidence-based prevention, how to do it. We have a special discount for junior doctors. We have talked with our colleagues from Vasco da Gama movement, and we have made really great discounts for junior doctors, and there is even a super discount free if you do your registration in the early bird registration period, and if you do it in a group of colleagues. For 5 colleagues, a group of 5 colleagues, there is really a super discount fee. So the registrations are already open, and please don't forget to participate and to come to Porto to join us. It's even better to be together with each other in the same place than via a webinar. But tonight it was really great. Ricardo, the colleagues are thanking you. Thanks a lot. Can we have a link to listen again offline? Yes, you will have in the EUROPREV website. Please wait 1 or 2 weeks and we will share the link in the EUROPREV website, as I mentioned before. Ivan, thank you very much for the webinar. Claudia, thank you for another brilliant presentation. Krista, thanks a lot. Were there 2 checks? No, in this webinar we only have 1 attendance check, okay? I shared the link, you go to that link, you fill the form, submit it, and it's done, okay? We have some webinars in Portugal where we do 2 attendance checks, one at the beginning of the webinar and another at the end, but this is not the case, okay? Today we have only 1 attendance check. And that's it, Ricardo. It was really nice and really great to have you with us. Thank you
a pleasure.
For all your goodwill and effort to explain and to answer all the questions.
It's my pleasure.
Please, you may now also say goodbye to the colleagues.
Okay, just to thank you for your interest and for following the whole webinar with a lot of interesting questions coming from everywhere. Also for some challenging questions, which are always good to receive. And the final word is to thank you also, Carlos, for the idea of having this in a worldwide with a worldwide audience. I think it is interesting. We always learn from different experiences, and it has been a grateful evening here to be here with you and all of you.
Thank you, Ricardo.
Thank you very much.
Dear colleagues, next EUROPREV webinar will be 11th June. It will be also a special webinar. It will be a collaboration with EQUIP. We will have Eva Arvidsson from Sweden and Piet van den Busch from Belgium. And the topic of the webinar is setting up a quality project about prevention in your own practice. So I think it will be really interesting. We are going to approach topics related with prevention, but in a concern with quality improvement and how to set up a quality project. Thank you very much. Have a nice evening and also a nice week. Bye bye. See you next time. Ciao.